This program is brought to you by Emory University.
Good morning. Welcome to Cardiovascular Grand Rounds. Our speaker today literally needs no introduction. It's a great pleasure to have Doug Morris as our speaker for Cardiovascular Grand Rounds. And I learned something new about Doug. You really were a chemistry major as an undergraduate. That's what I learned about Doug when I was thinking. But as you all know, Doug was a product of Baylor and Vanderbilt and did his cardiology training here and has been at Emory throughout his career. Is really one of our most revered and admired physicians, and certainly one of my favorite teachers. So I'm looking forward to learning some more from you, Doug.
Thank you, Bob. I want to address a subject today that many of you have first impression. You're going to say, well, this is boring, and what's he doing talking about that? You're not going to probably come out with a lot of increase in your medical knowledge, but it is something that I've taken an interest in. As we look at it, I'd have to say that whatever I say today, I have no financial disclosures or conflicts of interest in that regard. And also, as we look at our objectives, what I'm hoping we can do is find out what the healthcare problems posed to us by the elderly, to review briefly the physiologic and social changes associated with aging, to gain an understanding of the clinical consequences of these changes, examine the role of frailty, and then why should healthcare of the elderly be a concern for cardiologists. So these are things as we go forward. I hope that we can get something in. And I guess I asked my own question about why have I gotten an interest in this. As I said, a couple of years back, I went through all the stages of going from elderly to frailness to dying with my mother, who lived to 98 and a good life, but the last couple of years was a burden for her. Also realize, as we'll talk about, that this is an increasing problem. And as we go forward, you're going to probably, if somebody asks you what came of this lecture, some of you are going to say, well, we had this joker up there with placards and giving out pamphlets trying to push a certain agenda. Or we had somebody here that was a motivational speaker with a bully pulpit trying to tell us what we need to think about this. Probably the most of you would think, well, we just heard an old man with his daydreams. But at any rate, however you want to do this, that's what we'll do is go forward. I want to do this by presenting a couple of patients. First is a 94-year-old woman who was transported to the emergency room because of sudden onset of atrial fib. Now, she didn't know she had atrial fib. She was a fairly active lady, lives alone, and she started noticing this fluttering and things running fast in her chest that she had never felt before. And she called her doctor. One of her doctors is a pediatrician, and he said, well, let me come by and get you, and we'll take you to the emergency room. When she got to the emergency room, she was very anxious, fearful of what was going on, had a blood pressure you could see was quite high, had a systolic murmur. And the systolic murmur was thought to be aortic stenosis. That was confirmed by echo. And so she was referred to me as a cardiologist about her echo and aortic stenosis. Her biggest concern coming in is what was going to happen to her, because she lived independently, lived alone, and she was quite active, but she realized that she was slipping some. And the question, she had one daughter that lived out of a town, another community, who was welcoming her to come live with her, but that would be moving from the town she knew, town she liked living in, moving away from all of her friends, those that were still alive. And this was a big problem for her. And that was what her big concern was, not the aortic stenosis, but these things. Another one is an 84-year-old male presented to the clinic with exertional dyspnea and tightness in his chest. He had a past history of carcinoma of the bladder and had responded to chemotherapy, and that was inactive. He had carcinoma of the lung and had a resection of his right upper lobe. It had bilateral CEAs. It had deep venous thrombosis after one of his operations. And he had a hypertension and coronary bypass surgery. So he'd had a very active medical history. When he came in, he had no evidence of fluid overload, but his big concern was this exertional dyspnea. His echo revealed an ejection fraction of, it varied depending, and this is one thing I have with some of our imaging, is we had three different measures of his thing. One was MR, two echo, and it varied anywhere from 35% to 55%. His pulmonary function studies have been essentially normal. He had a stress test that was positive. We decided, well, we didn't have a good explanation for this, and maybe an angioplasty was what it was. Maybe this was angina equivalent. He got no benefit from the angioplasty. He had a BNP of 150. And so the difficulty for me was trying to decide, did this patient have trouble with his lungs or did he have trouble with his heart? For him, the difficulty was that he had a wife that was getting increasing dementia. And he had to schedule all of his appointments on the days that he called his day off. That was one day a week he had somebody come in and take care of his wife. The other times he was taking care of his wife and couldn't do anything else. Finally, we continued to muddle through this, trying to decide if his heart failure, trying to diurese him. That didn't seem to make any difference. And he finally came to the decision he had to put his wife into assisted living. He did that, and he had no more responsibilities, and all the exertional dyspnea went away. That this was probably more than anything else, the anxiety, and as you began to talk to him, you can see that the thing it was exertional dyspnea, but what I'd misinterpreted was the big exertion that carried him was him dressing his wife. And that was something that came in. So one is, as I'll stress through this as we go through, listen to these patients carefully, and a lot of times they'll tell you things you don't know. Why should we cardiologists be concerned about the elderly? One is, I hope as I go forward you're going to realize that this is approaching a crisis stage. That us providing care for this group of people. Another, we need to acknowledge the inadequate number of geriatricians. As people say, well, let that be a problem for geriatricians. There are not enough geriatricians in the world to deal with these people. And that's something we need to do. The other thing we need to see is that the impact of the most common cause of death in this age group is heart disease. So that immediately puts them into our office. And then we need to acknowledge that this is us coming up, and I'm a lot closer to it than most of you, but we're going into this group. And if it's not us now, it's our parents or our in-laws that we're all touch this. And then this is a statement that I think is appropriate. A society should be judged on how it treats its most vulnerable. This quote has been attributed to Nelson Mandela. It's been attributed to Gandhi. It's been attributed to Pope Paul VI. Probably all of them had some derivation of this. I thought the most profound statement of this is one that many of you maybe don't know who this guy was, Hubert Humphrey, who was a Democratic candidate for president at one time. But this is his thing. The moral test of government is how government treats those who are in the dawn of life, the children, those who are in the twilight of life, the elderly, and so forth. So I think it is something as we as a nation need to think about of how we're going to deal with these people. This shows you what we're up against. As you look at the common causes, these are the most common causes of that people die. And that is that you look up here and you can see that the big things is arthritis or heart disease. And in this group, in looking at heart disease, they left out hypertension. So if you put those in the group of hypertension, coronary disease is the most common. So this will bring them into our office. And this is part of the reason we as cardiologists have got to be concerned about these people, because they're going to appear there and they expect us to take care of them. As you go forward, you guess, what's the age? How do you define this thing? This is one thing that comes up. As you say, the young, old, 60 to 65 to 75, and you can see the other two. And as people said, an accumulation of changes over time is what aging is. As we go forward, we just begin to, and you'll notice that you accumulate things. You have pain getting up in the morning you didn't have earlier. You have, sore knee or something. That all these things begin to build up, and this is what makes us elderly. This is another example of what can happen with getting older. I think the thing you also recognize, though, as you look at the elderly, is not all of us age the same rate. This is a 75-year-old man. This is a 75-year-old woman. Same age, much different. This guy's still running 10Ks. This lady is having trouble getting around without her motorbike there. So what are the common changes of aging that we see? And most of you can tell me these, and so I'm not going to spend a lot of time. The cardiovascular things of aging are, first, the heart. you begin to get hypertrophy of your myocytes. They begin to get larger. You begin to get imposition of collagen in between these cells. And so as you go along, you're more likely to get hypertrophy, even if you have nothing else, even if you had no hypertension. The hypertrophy is a very common part of getting older, hypertrophy of the myocytes. The other thing that can happen is you look at your aortic valve, you'll get stenosis. As you live long enough, probably most of us will end up with aortic stenosis, and that is calcification of the leaflets. And then the far segment C there shows what happens to the mitral valve. It's not the valve that ages, it's the annulus that becomes calcified. EP-wise, our sinus node dysfunction increases. We're more and more likely to lose our sinus node. As we lose a sinus node, as one of the next slides will show you, we get atrial fibrillation. Another thing that happens is parasympathetic tone decreases. So you have something, aging of the sinus node itself says we slow down our sinus rate. Loss of a parasympathetic tone says that you're going to increase your sinus rate. And so these are in competition, but you'll begin to see both as you go forward. People with a faster heart rate, people with a slower heart rate. The things also we need to think is that not all these changes are just in the cardiovascular. One common one is the GI tract, and the GI tract loses this protective response. It loses the mucous membranes that go over it, and what happens is that you're more and more subject to the bad effects of drugs, things that erode, aspirin, non-steroidal or anti-inflammatory agents are much more likely to have an effect in the elderly because they've lost this protective mechanism, and they don't have a good ability to repair itself. Another thing you need to recognize is that as they go along and they lose some of the intestinal innervation, they begin more and more have trouble with reflux and constipation. So if you're putting an elderly person in the hospital, I'd urge you to put them on laxatives and put them on something to help protect their GI tract. Hepatobiliary, you can see they begin to lose some of our ability to metabolize drugs. And then I think, in my mind, one of the difficult ones today is the pulmonary. You have a decrease in vital capacity, and you're facing this thing, as I faced in one of those patients, of trying to decide, is their problem pulmonary or is it cardiac? Is it heart failure or is it losing vital capacity? I think as we go forward, you look at this thing, is that what we've got is an intersection of two things. That one, you have age-related pathology, which is what we've been talking about. That as we go through, we begin to lose things. Our arteries get stiffer, arteries get dilate, the arteries unravel and get longer. Our myocardium gets stiffer, and we have this, and then on top of that, we have other diseases that come up. And so they come up on a background of having a changed landscape, and it makes everything worse. And the thing you have to recognize as you look as we go older, and this is the number of comorbid conditions we bring to the hospital with us. If you get over 80, you've got just about everybody's going to come in with some other condition besides the one they're presenting with. This is striking, and so I think that what we do now is to say, okay, we got this problem of aging. What do we learn from it? As you look at this and you see the several things that happen, is that first on the bottom here you can see it's changing from what used to be a pyramid, and this was aging. This is, as you see, the number of people at each segment of life, each age of life, and they go and go, and it's a very straight pyramid. You can see what's happened now is that the death rate stays pretty constant until you get up in your 60s anyway. The other thing that this graph here shows you is that you have it right now, at this point, we have more people over 65 years of age than we have people less than 5 years of age. And so that's telling you what's happening in terms of what we're dealing with. There's a massive input. And if you look up at the top there, and this graph says the same thing, that per day there are 10,000 baby boomers that are going to Medicare. So this is a tremendous problem. You're talking about tsunami coming. This is what we're talking about is with us. This is another way to look at it. Another graphic shows it. And what they're looking at is a population. And you look at it, and this is in 2010. And what's happened is that you can see that over 85 years of age, The number that's increased is 351% increase in people over 85 years of age. Look at what happened at 100. Over 1,000% have increased at age 100. And so this is what we're talking about, is that this is a group of people that we've never dealt with before. We've never dealt with people this old. And they're bringing new challenges for us. This other one shows a similar type of graph from a different organization. What they showed is the segment, and this is over 65, that has increased. The most strikingly is this group at the top, and they've doubled. Although it's not as big as this size here, the acceleration has been much greater in this older group than any other group. So, why has all this happened? Why have we gotten this sudden increase? It's not because our birth rate has gone up. And you can see all the factors that one, maternal and infant mortality has certainly changed for the positive. Another big thing is lifestyle changes, that we have screening. We have a third of the people that come in with heart disease are picked up by some screening test. In cancer, about a fifth of the people that present with cancer are picked up by a screening test. So the screening tests have been effective in decreasing the sizable portion of the death rate. Antibiotics and vaccines have been important. And then the other thing we've done fairly effectively is we've decreased injury. We're a much safer society where you can just get in your automobile and look at that and you can realize that. But these are some of the things that have led to changes in life expectancy. So the first thing as we look at is why this has happened, why we pay attention to the elderly, is the size of the population and the fact it's growing so. The next thing is we look and try to study the elderly, we have to realize there's a paucity of data. That we don't have much data on the older population. And the reason is that most clinical trials, the cutoff is age 65. You don't see many clinical trials that are looking at patients after 65. And so the question is what do statins mean in these people? What do ACE inhibitors mean in these people? These types of drugs, we don't have good answers. This is a population that's not well studied. Part of the reason they're not studied well is people look at them and say, well, they're not going to live long enough for us to get a reasonable results. And so they're eliminated. The other thing is NIH did this, and this is what you might expect, is not only living longer, we're staying active longer. And what they found out is you look at age 65, that men are staying active almost 8 years longer. Women are staying active about 10 years longer than they used to be. This is just an example of certain things that come. And the 4S study said that post-analysis, that they would look at it and say, well, we didn't look at the elderly group. We need to look at that. So they looked at them and decided to try to make something the elderly group. But what happened is they didn't have anybody over 75. They made the elderly group 65 to 70 and not any older than that. Again, the Prosper trial came in and said, we're going to look only at people from 70 to 82 and look at risk factors. And what they found, interestingly, is that if you use statins, they had an effect for men. They didn't have an effect on women. And then they also looked at they had an effect in secondary prevention. They would not have any effect on primary prevention. But this is the only data we have out on these things because they were not looked at. This study is the very elderly and hypertension. And they did show, if you look at this, and what they'd used to lower their blood pressure was indapamide, a long-acting thiazide, and then an ACE inhibitor, and looked and found that, yes, up to average age of 83, that treating the hypertension was very important. So there's a little data there, but not a lot. Another thing we need to know about as we look at the elderly is a different presentation of diseases. And this is one, the Shep study that looked again at hypertension. They said that you could, if you reduce the blood pressure from 170 to less than 160, you lowered the stroke rate by 33%. If you lowered it less than 150, they didn't get much more. And yet you can see that a lot of times in hypertension, you're trying to push them and getting them lower and lower and lower, and then somebody else is coming in and trying to face the problem of postural hypertension. So know what the data says, and what they're saying there is that you strive to get down to like 150. You probably don't need to push it further. Now, the other thing that they've brought out is this graph here. And if you look at it, it has kind of the Nike sign. And what they're saying is you also in the elderly need to pay attention to diastolic blood pressure. That if you get a diastolic blood pressure down below 65, your death rate starts going back up. And so as you try to push that systolic pressure down, pay attention to diastolic pressure because that is important. So often we ignore that because we're focused on the systolic. So again, some data out there on the elderly, what we do about it. These are the other things that you look at. Myocardial ischemia, that you frequently, your presentation is different. And all of you have been faced this, whether it's myocardial ischemia, whether it's aortic stenosis. And this is something I've been impressed with, is they always teach that aortic stenosis is that three things that you need to think about with symptoms are syncope or near syncope, angina, and dyspnea. The thing I've found about is we look at the TAVR people, that two big things is just exhaustion and some decrease in mental function. And this is not what we're taught in the textbooks. The other thing is that you look at heart failure and all the various ramifications that heart failure can present. And this makes it particularly difficult in trying to treat these people. And then, of course, you can have situations like heart failure that presents with, that you can diagnose heart failure based on pulmonary crackles. The most common reason for pulmonary crackles is atelectasis. The most common reason for pedal edema is just venous insufficiency. So pay attention to what you have. This just shows you the difference in aortic stenosis in the elderly. Here that you've got leaflets that are not fused but stenotic because they're very rigid, versus aortic stenosis in a younger age group where you've got a bicuspid valve that's fused. This is some other changes that you don't think about. 60% of deaths attributed to acute myocardial infarction in patients over 75. So this is, again, what we're doing is, and this makes it tough as you try to look at these people and say, what do I do to try to treat their infarct? And you've got to realize this. In men, age 75 to 84, 42% of MIs are silent. That they're, or should say unrecognized, that they come in with symptoms, not the typical chest pain that you're talking about, but most frequently is exertional dyspnea. Second is fatigue. You can see that in young men, most of them have typical features. This is another problem that you run into. Only 17% of people with heart failure are less than 65 years of age. So you look at what we're dealing with now, and you look on the wards, you see that the biggest bulk of what we're treating is heart failure. And most of these people are above 65. Among people at age 80, most of them have preserved heart failure. They're not reduced heart failure. That is, that they've still got good ejection fraction. But in the younger people, that's not the case. And what's growing is this: heart failure with preserved ejection fraction, not heart failure with depressed ejection fraction. Atrial fib, you all recognize, it increases with age. This is the other thing that you look at and try to deal with the patient, the elderly patient, is this, and that's a constant decline in renal function. As you go through that, recognize that there are some things we need to pay attention to. Remind yourself that thiazide is a little value when you get when you get clearance, glomerular coloration or creatinine clearance, less than 30. Rosuvastatin, you should start with a smaller dose if you're starting that. Now, atorvastatin, you can keep the dose the same. Rosuvastatin, you need to reduce the dose if you get down to to clearance of less than 30. And you need, when you get that low, less than 30, avoid rivaroxaban and dabigatran. You also, if you get down less than 15, you avoid apixaban. So apixaban you can give a longer time with more reduced more reduced clearance than you can with the other two. This is the thing that I see that probably we make the most mistakes with, is a tendency to want to stop ACE inhibitors. ACE inhibitors are renoprotective, not primarily renodestructive. And that is that what you're doing is that a lot of times you come in and you see the creatinine rise and somebody says, well, we've got to stop the ACE inhibitor. And ACE inhibitors, you probably, before you stop them, should see an increase in the creatinine clearance by 30% or more, and usually give them a month before you stop the drug. So it's too quick to stop. Another reason you might want to stop is if the serum potassium goes up. But again, the message is to be slow about it, that they are protective. Another drug gets a bad rap is naproxen, and that is if you look and say non-steroidal anti-inflammatory agents, what do we do with those? And a big dictum is, you know, if you had heart trouble, you stay off these drugs. One, they can make your heart failure worse. They can make your hypertension worse. They're more likely to have a myocardial infarction. That's been shown with every one of the NSAIDs except naproxen. So if you had to use an NSAID in a person with a heart attack, a person with coronary disease, use naproxen. It's the one now. There's still some question about it, but it's the one that's never come up to show any damage where all the others have. So those are things that you need to remember based on a decline in renal function. Another problem with this group of people is compliance. And you can see why that might happen, is if you look at the number of people that were on more than 5 drugs, 1998 is 54% of these patients, elderly patients. These are people over 65. By 2003 is up to 67%. Look at the number on 10 drugs. So you can see that why the polypharmacy can lead to problems with taking the medication. Most of these drugs are prescribed, but some of them you always take non-prescribed. So the patient comes in, be sure and get a good drug history of what they're taking from their pharmacy as well as what you prescribed. And a lot of times we think the compliance is just that they forget. A large part of it is cognitive limitations that the patients forget to remember. But some of it is a conscious decision. The patients say, I can't afford the drugs. And you can look at this as this is what happened if you tried to change and look at the new drugs. This is the drugs that you would use right now for heart failure. Fairly cheap. These are the new drugs. Now, recognize that you can go through and you can get a discount. You can get the nurses or people in your office to work with them, and you can try to get a discount for these drugs. But remember, that's not easy to do, and particularly not easy to do with a person who has limited cognitive function. So that's another problem for them about the compliance is the cost of medicines. This is something that you see, that the drugs that have the most adverse events are these listed. I think it's a disparity in healthcare delivery. We talk about where the disparities are, and I think the greatest one right now is in the elderly. One problem we try to do is we try to put the elderly patients on our time schedule, that most of our visits are scheduled for 15 minutes. You get an elderly patient into your exam room and try to deal with them in 15 minutes, get them to get up on the examining table, getting them to disrobe, put on a hospital gown, trying to get their history. It's almost impossible to do it in 15 minutes, and yet we put that same onus on them and ourselves that we do on younger patients. This is something I think is important. We were just talking about this earlier, and then that is that what we need to do is spend more time finding out what matters to the patient, not what is the matter with them. We come in and we see this patient's got heart failure, we got this patient that's got some other problem, and we don't take any time to ask a 75-year-old, what matters to you? What do you want to do? And someone will come out and say, I've got a granddaughter that's going to be married next April. I want to be alive for that. You got somebody else that's going to come in and say, I've got bingo that I play once a week, and I want to be able to do that. I mean, so we need to find out what makes a difference to them, because that's why we've got to treat them. Again, we've talked about this, that you have a lot of drugs and have cross-activity of those. And the big thing is, these patients rarely come in. In med school, we're talking about find the chief complaint. These people rarely have a single chief complaint. They have multiple ones. I think this is something else that we need to be careful about. Is if an elderly patient comes in, I've caught myself doing this, they come in with their family, next thing you do, you're talking with the family and the elderly patient's sitting over there being ignored. And so you've got to be able to ensure that you bring them into the conversation. They might have a big disagreement with their family about things. And also, as I said, we often look at this and you come in and somebody says, what's in your clinic today? And they say, well, I've got 5 patients over 70 to see, and I've got one with aortic stenosis and one with mitral regurg. You say, boy, that's 2 interesting patients, and we forget the others. And appropriately so. They're hard to deal with. They're hard to make a diagnosis. Now, this is the striking thing as we go forward about this. That among these group of people, these elderly group, there's another group of people that have a 6 times higher mortality rate over the next 3 years. If we take all the elderly people, and out of this is a subset, they have a 6 times higher mortality rate in the next 3 years. We call them frail. Now, this is the problem with frailty. One, there's no consensus as to defining characteristics of frailness. Frailness usually, and we'll talk about it, is the loss of muscle mass and muscle function, but it leads to slowness, and the best way to do this is get a walking test and to say, how far does it take you to walk from this point to the end of these tables? You set up your length, and you measure and you get time. They'll slow down with frailty. Another one is weakness. And the most common way you measure weakness is you get a hand grip, and you measure it and let them see what happens with that. Another one is exhaustion, and that's something you just get the patient to tell you about. Another one is weight loss, and if they've lost 10% of their body weight within the last 6 months, that's striking, and that's a big thing of frailty. People quit eating, their body weight begins to go down. So those are things that you look at, and problem is that some people say, I've got to have measures of all 4 of those to call the patient frailty. Some people say, just a get up and go test, which means you sit them in a chair, you have them get up, you have them walk 10 paces, how long that is. That's all you need. And it is the best test of measuring frailty, is that single test. But some people would say, well, that's enough. But this is what we do. And then the other problem is that we can't, even if we recognize it, we can't measure the severity, and then we have no reliable means of predicting prognosis. That is, what does it tell us? Now, I would say at Emory here, there's 2 groups that are looking at it. The urological surgeons are measuring frailty on all their patients, trying to get a handle on who do they not operate on. And then the vascular surgeons are looking at it. And I think it's something we need to think about as we go forward, is because we're going to never find out how to measure it well. We're never going to find out its prognosis until we begin to identify it. And at this point, for the most part, we don't identify it. This is some of the faces of frailty that you face today. This is a gentleman you might not recognize from the UK that killed his wife because he knew he was declining and there was nobody else to take care of her. And this made national headlines. You recognize this as Paul VI, John Paul VI, who got, I guess it's Paul VI, wasn't it? I think it's Paul VI. Ronald Reagan, George Bush. These are people that you recognize, and all of them have become frail. And as you see George Bush today, you recognize frailty as you saw him. Again, the thing we need to think about as we talk about this is that the line between elderly and frail is not very strong. And this is a statement made, nature never draws a line without smudging it. And what it's saying is that we draw a line trying to separate elderly and frailty, and the separation is not quite so clear. You'd like for it to be very clear because you'd like to identify this group that have such a bad prognosis and do something about it. Anybody know who made this statement? Winston Churchill. Interesting. This is what you do, is you take and try to look at the data on it, and taking, in this group, they took 4 measures of frailty. If you had to have three, they had 5 measures of frailty, and you had to have 3 of them. But what they showed is that at age 65 and older, of all the people that are elderly, about 7% of them we'd classify as frail. As you reach 80, 30% of them are frail. And again, you're recognizing that if you're taking a group of people that have a terrible mortality here. This is another study, similar type of thing, as they look at increasing frailty starting at age 75, going on up, and they are saying that everybody that reaches 100 is frail. Some other people looked at it and said that if you reach age 98, you have to be frail, that the human body is not made physiologically to go past that time. But it's people with a terrible prognosis. This is what happens to them. You can't see this very well. There's a big arrow that comes out, and a big problem that causes most of this is just sarcopenia. You begin to lose muscle tissue. And with it, you lose your independence, autonomy, your physical activity begins to decrease. You have an increased risk of falls. And this is what happens. If you take an older person that has a minor illness, you take the top line here, and they're cruising along, doing well, and they have an illness, they drop down, they get less independent there for a while, they don't function as well, they bounce back up. The frail person comes in, they're not performing at the same level this person is anyway. They come and have an illness, or they have an operation. And this is a problem with an operation, is that you go in, you're looking at them at this state, and you measure them at that state and say, well, they look pretty good. Then you do the operation, they plummet, they become very dependent, and they never get back to the baseline. And that's the problem we face, and that's the problem you'd like to say, how do we identify these people? What do we do about it? So, the one thing is then, if you look at frailty, you'd say that we should be able to recognize this by taking one of our measurements, or taking 3 of our measurements. And that's true, but the other side of frailty is what that graph just points to, is that a lot of times you can't tell it until you put a stress on the body. And this is one of the patients that I started to bring up earlier today, was that a man that came in, was transferred here for aortic valve replacement TAVR. He was described as a robust, very productive man at age 81. He had his TAVR, and then he crumbles. He becomes demented. He begins to see butterflies on the wall. He begins to see a lot of things like this. His blood pressure becomes very difficult to control, up and down, up and down. And so he looked good, and there's no way to measure that he wouldn't do this until the event happened, and then he crumbled. And that's part of the challenge for us, is how do we measure this and say some of these people are better off not having a procedure? And that's difficult, and that's where, again, I think we're going to need measures, because you go in and tell a family, I don't think that your brother needs to have this operation, and they ask you why, and you say, well, he doesn't look like he could make it to me. And that's where we stand right now. Basically, what we do is we use the eyeball test. We look at them and say, and do that, and deny them stuff. So you've got to realize that frailty is not only a state of disability at the time, but it's a state of the potential disability. Some people have said another reason cardiologists should see these people is that this is a cardiovascular disease. That these people more often are obese, less physically active, they have an elevated hemoglobin A1C, they're previous smokers, and they have ankylobacter index that is abnormal. This is another point that people have made about frailty, is it's possibly an inflammatory condition. That you can look at IL-6 and some of these things and measure it, and it's increased. Some people say one way when you look at somebody who's frail, measure CRP, that should be something. But again, we're not sure of that, but there is probably some element of inflammation that goes on here. How do we recognize it? How do we stop it? Is there a problem? This statement seems to be very true. You're only old as you think you are. And that is, it does look like of all the things that you're trying to measure in this thing, is a patient's approach to life is important. And this type of thing, that people that are staying active, staying involved, are very important. It's two things that you look at as you try to say, how can we extend the good health of an older person? The two things come out is activity and social connections. That all the other things we measure, there might be something out there that we're not measuring, but you can't point to it and say that's important. But you can point to activity, them staying active, and them having some social connections. And this is what, again, you can see the first lady we talked about today, she was afraid of moving because she in her own mind realized she was staying active. She realized that she was beginning to decline, but she also realized if she moved, all of her friends were going to be gone. And she might make new social acquaintances, but that's something that you have to think about. So I think as we look at this, these are some of the things that I think we should do. Know the limits of evidence-based medicine. That is, don't get so focused that you're applying the evidence-based medicine based on 55 and 60-year-old people to the 80-year-old, to the 75-year-old person. So you've got to keep that in mind. I think one thing is also maintain the patient's dignity. I'll never forget Dr. Hurst, one of the last things that he told me, he said, Doug, he says, the thing that I realize is that I've lost my independence, I've lost my reason for being, I've lost my dignity. And at that point, he felt like life was ended as he realized it. And that's something I think we need to be assured of is, and you can forget this, that you can take the patient and they're older and they're difficult to get out of bed, they're difficult to get a chair, and the nursing and everybody begins to forget them. And that's the thing I think we've got to focus on them and keep them. I think that this is another thing it's very important as you start dealing with the elderly patient, is establishing a rapport with the family, because families get suspicious when we start talking about, well, we're not going to try to extend their life. They maybe understand it in one sense, but in another sense they think you're telling them, we're giving up on them, we're not going to do any more. So you need to establish good rapport. Again, I think that we need to try to refocus this on the quality of life, not the length of life. Somebody else told me this, and I think they're probably right, is I'd always stress that you need to keep these people doing activity, doing physical activity. Their point was, don't get them to do exercise, but make them continue to be active. You know, don't let them, if you start saying you got to do exercise, and one thing you come in and say, you need to walk a little each day. Doc, I can't walk. I said, my hip just hurts me every time I get up and walk here. I can't do that. So, again, recognize that some people can't do a typical walking exercise. Find something they can do actively, whether it's hands or arms or something else, but I think that that's important. And again, I think we should need to promote social interactions. And that's where I'll stop. And what I'd like to do is hear your thoughts on this, because I've got a lot that we'd like to do about this. The first thing is to understand it better. The second thing is convince people that we need to pay attention. As Hubert Humphrey said, this is one of those vulnerable parts of our society. And I'm struck, as people say, as you go along in your career, your patient base gets older and older. And I think that's what I see in mine. And a lot of them are coming in with this thing of frailty. So I thank you and open it up for discussion.
Thanks, Doug. That was great. I'll start out with a sort of question/thought. So, you know, one of the things that always strikes me is that we're not geriatricians, and we don't have that skill set or that training that our geriatric colleagues have. And should we think, given the growing burden of cardiovascular disease and the elderly, should we think of a different cardiology training program for a geriatric cardiologist? Should we think of we've tossed this around before, a non-invasive sort of 1-year cardiology fellowship. Should we as a group thinking about, maybe a 1-year specialization for geriatricians in cardiology? Because a lot of this is non-procedural stuff, things that probably better handled in a more familiar zone with a primary provider, et cetera.
I think that's a very appropriate question. I think the most important thing is you're asking, should we think about it? Yeah. And I guess if I ask anything is, I hope all of you go out of here today and at least think about some of this stuff, because that's where we need. Right now, we're not giving any thought to it. Just out there, and as I said, there are little segments that begin to look at it, but we do need to think about things. I'd thought about also, could we have a clinic that is run by, say, a PA, and what you have is a physical therapist there, you have a nutritionist there, you have all the substances, and the elderly come in, and they're seen primarily by these ancillary people. Having a physician there is a final sign-off, but maybe it could be the physician like you're talking about. The physician has just a year of training in cardiology, but I think somehow we've got to come up with an answer here.
I'll just throw in one more plug that, the CTSA grants, for the, sort of clinical trial infrastructure, one of the functions of that is special populations. And of course, one of the special populations the NIH has defined as in need of additional focus is the elderly. And so that's, at least at the NIH has sort of figured that out, that, chopping off these clinical trials at age 65 is not a valuable approach going forward.
I have talked to one of the general surgeons here, and they have some interest in trying to do something like that with us, actually.
Doug, I really enjoyed, you brought up so many good points that lot to think about. I think as we look at the different disciplines that have been involved in this, I think nursing historically has had a big role in assisting our elderly patients, understanding them, being there, discussing things with their families. I think in our offices we find that our nurses and those who have gone through the nursing discipline and into nurse practitioners do a great job, often a better job than our physicians do in recognizing those. I've certainly learned that in our heart failure practice. And the other thing is I've learned a lot from our palliative care specialists over the last 5 years or so, and reading their consults and talking to them because they do focus on what is important to the patient, and then how do you get an understanding of what's important to the patient and deal with that with the family members. And I also think that inherently there are certain physicians who are just have a natural ability to do this and to recognize things. I know when I would discuss things with my father, who's a 85-year-old cardiologist, still sees patients twice a week, but when I discuss things with him about how do you deal with a difficult situation, he said, well, I've always found that if you just ask the patient what they want with the family in the room, that's incredibly helpful. But these things are very important. The other thing I'd like your thoughts about, and you mentioned it a little bit, but we're so focused on, quote, quality in medicine and looking at best practices and documentation of that. And a key example would be use of aspirin in coronary artery disease, use of anticoagulation in atrial fibrillation. But how many studies are there really that look at a patient who's 80 years old and over with the combination of an anticoagulant and aspirin, or just with some of the anticoagulants alone? And so when these patients come in and their skin is all bruised and they have ecchymosis everywhere, and a number of folks feel that they're held that, well, they've got to be on an aspirin, they've got to be on an anticoagulant. What are your thoughts about how we deal with those situations?
I object to that. I think that's one of the problems. As you say, they look at it and say, well, this is evidence-based medicine. Everybody's got this problem, has to be on this medicine. They forget how old they are. And I think that, and we came in recently when I was attending rounds, somebody come in, they'd be on 4 or 5 medicines, and the next thing was say, well, they're still having some heart failure. We got to add some more medicine to them. Well, probably the right thing to do is take away some of those medicines that they do. And we forget about things like you got them on a thiazide, and the thiazide at the creatinine clearance they have is not active anyway. And so I think we do need to pay attention to those things. The thing I worry about with the geriatricians is that I recently had the experience of a patient that was sent to me, had been a patient that I'd taken care of in the past, had moved, she and her family had moved down to the south side of town. They got another cardiologist, and then her husband died, and her family now is putting her into assisted living. They brought her back up here, see me, and then they wanted us to refer to a geriatrician. I could not get anyone at Emory to take care of her. I mean, I call my office call and trying to get different things, and they're full. I mean, and so who suffers? Well, the patient suffers. We don't deal with them, and that's my problem. I agree. It'd be nice to have somebody besides a cardiologist seeing this thing. But as I said, what happens is they end up in the cardiologist's office because it's such a common complaint. The other common complaint is musculoskeletal, but musculoskeletal causes pain. Most of them are not subject to dying from musculoskeletal. You tell them a heart disease, their fear is, well, I'm going to die from this, so I got to have a doctor looking at it. So that's part of the problem I have with the geriatricians. I'd like for them to take this thing, but I don't see them grabbing hold of it.
Doug, I also really enjoyed your talk and learned a lot and remembered many patients as you described them. I wanted you to comment on, as an interventional cardiologist, on how some of what you bring out plays in the acute setting. Because as you know, we often don't have the time to understand the patient's social situation, and they're presenting with an ST elevation MI or cardiac arrest. And what can we do in the acute setting other than to try to reach family? And one of the other things is maybe as cardiologists we should also address the will that patients should address that in the more stable situation. Because I mean, for us, it's a real challenge to make difficult decisions, not only about taking people to the cath lab, but then how aggressive to be, and often those decisions have to be made pretty quickly. So, any words of wisdom?
No, I think you touched on it. The right thing to do is try to address that when you're seeing the patient in your office before this happens, and get them to talk about it and let their family hear what they want to say. And most of them will come out and say, well, I don't want this, or I don't want that done when I do it. And I think that's the best way, because you're right. When you come in, there's this push to get things done, and you can't just use an age. You can't say, well, I'm not going to do it over 85. That's what the UK have done in some things, and what we did originally in this country with hemodialysis was you had an age cutoff. But I don't think you can do that because of the difference in aging. But I think the answer is just to know beforehand, best you can. Of course, a lot of people come in you've never seen before. But
Okay, well, with that, we'll thank you very much, Doug. Yeah, thanks.
The preceding program is copyrighted by Emory University.